Soft cataracts may be difficult to operate if phaco is the tool. So in this video today we'll see the situation. This is an 80-year-old individual in whom we expect some amount of nucleus hardness, but on the contrary, the nucleus was not brittle and hard, rather it was more amorphous and mushy type, that is just like clay. And these nuclei present a unique problem when phacoemulsification is tried. So as usual, a clear corneal incision 2.8 mm under topical anesthesia, and this is the steep axis, so the axis, the main port has been created at that portion, and there was some unwanted movement by the patient at the exact moment when the flap was being created, so it has resulted into a extension. So now this needs some amount of management. So we are reassessing the situation by putting on some viscoelastic and looking at the flap position. So here we see that there is actually a portion of the capsule which has detached itself, so there is free flap. So the axis is being reinitiated by creating a new tear at the margin of the defect created by this free flap. Using the non-dominant hand to create a capsular axis is a little tricky, especially if the experience is not as much as with the other hand. The other axis has been completed, which is satisfactory. Side port has been created, and now going in for hydrodissection, we can see a posterior wave. And it's always good to create a hydrodelineation in soft cataracts. It defines your nucleus. So now proceeding for phacoemulsification, and the unique problem with these cataracts is that they are clay-like and they are amorphous and they are not like a formed hard nuclei. So some amount of hardness is important for phacoemulsification, because the phacoemulsification process involves a proper disassembly of the nucleus by creating cracks in the nucleus. And as we can expect, that cracks can be created only in a hard brittle object rather than in clay. So I will see that the unique problems are that first of all there is very soft nuclei, so it's difficult to bury confidently into the tissue because there is a constant fear of going through and through into the nucleus, which may cause a PC tear with a nuclei in the bag. Second problem is that whenever you try to catch hold of nucleus by burying the tip, the pieces of the nucleus, they simply bite off from the main nuclei, and there is no holding power whatsoever left for the phaco tip to hold on to. So a clay nucleus like this simply detaches, the piece which you hold on to detaches itself, and you are left with a large crater in the center after repeatedly trying to catch hold of the nucleus for attempting to crack it. So one way of handling these nuclei is to do a chip and flip technique, which works in a way that you create a bowl sort of structure by eating away the central portion, and once this central bulk has been removed, only a central plate and a peripheral rim is left behind, and this can be flipped away from the bag and then can be consumed safely. So the concerns are mainly that the soft cataract doesn't allow any holding power to the tip, so the chopping maneuver fails, and the capability to go ahead up to the deepest part of the nuclei are limited, because one is always concerned about the phaco tip going through and through and hitting the posterior capsule, and in that scenario the posterior capsule is bound to get torn, and with a large portion of the nucleus in the bag and the posterior capsule getting damaged means only one thing, that the nucleus is going to sink into the vitreous cavity and cause a further complication. So here the surgeon is trying to rotate the nucleus and sees an opportunity where the nuclear plate can be flipped up by catching hold at a particular point. But because the nucleus is so soft that there is hardly any capability of the nucleus to be held by the phaco tip, because as soon as the vacuum is created, that portion of the nucleus simply bites off. So it was taking long time to get this out. So we'll just see what is the change in the strategy which can help here. So now the phaco tip has been rotated down so that it is properly aligned with the surface of the nucleus, and so the holding power improves. So instead of having a bevel up, the surgery is being done with the bevel down. This gets the occlusion better when compared to the bevel up situation, so as just the aspiration can be used to get a good grip over the nuclear plate which has been left behind, and then this plate can be dislodged from the bag, and once it is dislodged it can be consumed. So the strategy has worked, and now we have the epinucleus and some amount of nucleus left behind, which is now amenable for management, because once the bag is partially empty, it is easier to manipulate the pieces which are remaining back and safely remove them. So keeping the bevel down, the surgery is being proceeded, and we can see it's a thin plate. It was very vulnerable for full thickness defect if the conventional technique would have been used, and this is how the occlusion can be achieved without using a phaco power. And once that portion of the nuclear plate is out of the bag, phaco power can be applied to consume it. So this was a partial modification in the technique which worked for this particular case with a soft and mushy nucleus. Getting hold of the remaining portion of the nuclear plate, applying just aspiration, and then switching to phaco power once the nuclear plate is out of the bag. So this seemed to be the most appropriate, safe technique for this particular cataract, which is also known as chip and flip, although this was not the plan, but it has to be conducted in this manner just to be on a safer side, avoiding any complication. So here we can see the nucleus has been consumed now, and just some amount of cortex is left behind, and this becomes now a routine situation where the cortex will be peeled away from the posterior capsule by catching hold of the anterior end of the lens fiber. It's always important to keep a watch at the aspiration port so that it is facing towards the surgeon, so as to be confident what is being aspirated inside. Now implanting a single piece hydrophobic monofocal intraocular lens in the bag. The trailing haptic has not gone into the bag, so it will be dialed into the position. So basically this is a demonstration of a cataract which was unexpectedly soft. So the phaco technique of horizontal chop failed here, and we had to switch to a modification of chip and flip technique so as to safely remove the nucleus. This is the post-op day 1 picture, which is satisfactory in a sense that the IOL is well placed in the bag, cornea is clear, and the visual gain was significant. Thank you.